Next is Dr. Rajneesh Singh, Robotic HJ for benign stricture, and how it differs from open hepaticojejunostomy.
Morning. It's a pleasure to see you all here. I'm actually committing a sort of a sacrilege by presenting this. Legends of biliary surgery talk before me, talking about principles of how we should do this operation. So really, this is not a one-off surgery that we kind of worked on. We actually worked on this for the last 1.5 years, and essentially trying to tick all the boxes which my eminent speaker before me had described, that these are the boxes you have to tick to get a good operation. I hope to do that, and then let's see whether we can move forward or else say that let's throw it aside. So I present 3 cases. We have a little bit more experience than that, but 3 typical cases of, there's a voiceover here, so how will I get that voiceover? It's not coming there, no? So somebody has to put it on the mic. It's audio. Audio.
Very stricture. Greetings from SGPGI Lucknow. In this video, we would be demonstrating the feasibility of robotic hepaticojejunostomy for post-cholecystectomy biliary stricture. Robotic hepaticojejunostomy should be measured against the established standard of care, that is the open hepaticojejunostomy. We would be covering the technical aspects of this in this video. The steps of the procedure are similar to open surgery, with some key differences. Perihepatic adhesions are not divided and allow natural retraction of the liver away from the operating field. ICG cholangiography often helps in localization of the bile duct at the hilum.
Is it moving?
The duct lumen is opened wide and extended to the left duct, and roux limb is created just as in open surgery. Anastomosis is preferentially done with interrupted 5-0 PDS sutures. Pre-placed sutures are mostly avoided.
I hope it's moving.
Patient position is supine with steep head up position. 3 robotic arms of the Da Vinci Xi system are used, and ports are placed in a straight line at the level of the umbilicus. In small built patients, the ports are moved down by 1 inch. 2 assistant ports are placed in the flanks as shown. Case 1 is a young lady who underwent lap chole and thereafter developed a bismuth type 2 stricture, underwent a hepaticojejunostomy elsewhere. She developed a strictured hepaticojejunostomy and presented to us with cholangitis. Extensive adhesions may be encountered in this operation. Hence, initial adhesiolysis is done by laparoscopy. Thereafter, the robotic ports are placed and the robot takes over. After reaching the right upper quadrant, robotic adhesiolysis is done in the subhepatic location, lateral to medial as in open surgery. The loop of jejunum used for hepaticojejunostomy by the earlier surgeon is localized and followed up to the hilum to get to the anastomosis. The segment 4 is mobilized off the hepatic hilum to enable access to the hilar plate, and the hilar plate is lowered to visualize the bile duct above the anastomosis. A flexible needle is used to aspirate bile from the bile duct to confirm the location of the bile duct. and the hepatojejunostomy previously done is dismantled and the bile duct is opened. The opening of the bile duct is then extended to the left and to a certain extent to the right to enable an opening of greater than 2.5 centimeters. The anastomosis is done with the pre-existing loop of jejunum using interrupted 5-0 vicarious sutures. Pre-placed sutures are avoided to avoid entanglement of the sutures. However, the last few sutures may be pre-placed to avoid taking the posterior wall. After completing the anastomosis, bile leak is checked by using a white gauze piece to look for bile stains. At 6 months follow-up, the HIDA scan showed good clearance at 1 hour. Case 2 was a young lady who presented with a bismuth type 2 stricture following a lap chole elsewhere. The operation begins with general adhesiolysis to expose the undersurface of the liver and reach the hepatic hilum. To identify the bile ducts, ICG is given at 6 a.m. in the morning on the day of surgery. Usually these patients have a cholestatic liver, hence the clearance of ICG is delayed. In this case, the bile duct was still not identified, hence we moved to the infracholic compartment to construct the rouleum awaiting the clearance of ICG. The retrocolic tunnel is made to the right of the middle colic vessels. This has to be carefully done to avoid trauma to the duodenum, the middle colic vessels and the mesocolon. The rouleum of the jejunum is then prepared. The bipolar instrument used in the left hand is enough to divide the mesentery and achieve hemostasis. The rouleum is then taken up through the retrocolic tunnel. Remember that robotic instruments are not very friendly to handle bowel, so it has to be carefully done. The bile duct is conformed with a flexible needle as in the earlier case, and when switching to the ICG mode, we could see that the ICG has reached the biliary system. This is the favorite part of the operation, where dividing the bile duct, alien blood seems to ooze out. The incision is then extended to the left to achieve a lumen of more than 2.5 centimeters. Anastomosis is done, in most cases now, using interrupted 5-0 PDS sutures. Once the anastomosis is done, leaks are checked for using white gauze piece to look for any bile stains. Thereafter, the operation is completed by doing a jejunostomy in the infracholic compartment. Case 3 was a young girl who had an isolated right duct injury after a lap chole and developed a right duct stricture. The left duct was stented and draining well. The initial part of the operation consists of adhesiolysis to access the hepatic hilum. This was a young lady with an isolated right duct injury following a lap chole. Hence, the left lobe was nice and supple and was retracted using a Nathanson retractor. ICG was given to this patient at 6 a.m. on the morning of surgery. On the Firefly mode, it is seen that the ICG was still retained in the right lobe even 4 hours after the injection, and there was no ICG in the right biliary system. The left lobe, on the other hand, had nicely cleared most of the ICG. One can see the clips which were inappropriately placed at the previous operation. These clips were removed and the segment 4 of the liver was mobilized off the hepatic hilum to access the higher plate. The higher plate was then divided to lower the biliary system into view, and the right duct was then opened. On opening the right duct, it was no surprise to find white bile. The ductotomy was extended to expose one of the sectoral ducts. There was no bile excreted, no ICG excreted in the bile even thus far. A previously placed pigtail catheter for a collection in the gallbladder fossa was then exposed in the gallbladder fossa and removed. The posterior septal duct was identified and opened and cannulated with the 8 French infant feeding tube. The tube was used to extend the opening of the duct a little bit. A rulum of the jejunum was prepared as in other cases and brought up in the retrocolic fashion. The anastomosis was done using 5-0 interrupted PDS sutures. The last few sutures on the anterior wall are pre-placed to allow for good placement of the bites. The anastomosis is then inspected for leaks using a white gauze piece to check for bile stains. Even at the end of the operation, the right lobe still has not started clearing the ICG, while the left lobe has mostly cleared the ICG. To summarize, robotic hepatic jejunostomy is feasible and holds up well against the standard of care open hepatic jejunostomy.
Dr. Rajneesh, when I was asked to chair this session,
Thank you
I
for
said
your
I'm
kind
against
attention.
robotic hepaticojejunostomy. The reason is, especially in a government hospital, in Gangaram it costs more than 1 lakh extra. Secondly, you have to replace all the capital cost is huge, the recurring cost is huge, and you can't feel, and there is no long-term follow-up. And I would like to see a comparison of the advantages of robotic versus standard open, of which we've done more than 900. And Lord Cohen of Birkenhead said, just because an operation is feasible doesn't mean you should practice it. And I certainly, in a government institution, even in a private institution, would not advocate robotic unless it showed major advantages.
Radhakrishnan.
Patta Radhakrishnan from Chennai. There was so
Closer to
much
the mic.
hype.
You can raise it up, I guess.
Well, there's so much hype about an axis loop hepaticojejunostomy in the past, whether it's into the skin or the stomach. Is it been an abandoned procedure, or is there still some role for it in the present hepaticojejunostomy procedures? Rajneesh and Dr. Yadav to respond.
I think this possibly is for Yadav, Dr. Yadav, but nevertheless, we have abandoned it completely. There are reasons for and against. Probably this is not the podium for that kind of a discussion. But to be honest with you, I really don't know of patients who have actually benefited from access loop wherein procedures have been done, barring one team in the entire country, which I think is CMC Vellore. Is Phil Thomas here? I don't think he's here. I don't see any data of access loops actually being used to help the patient and getting results out of it. Far too many access loops are created. How many actually use is data I would really love to see before commenting on your question.
Dr. Yadav has a comment on this?
Yeah, I do. Andrew Gums from Paris. I wanted to compliment you on a beautiful video. There's actually a group from Mexico that reported on laparoscopic repairs for this about 10 years ago, and I believe they reported very nice long-term follow-ups a few years later, showing very nice patency rates, even when compared to historical old open controls. So I just wanted to hear your comments on how you think, if there are any benefits to the robotic as opposed to laparoscopic, because a lot of people tend to forget laparoscopy.
Yeah, the same team actually reported about 100-odd patients of robotic. This is about 2 or 3 years back, and they had a reasonable long-term follow-up of more than 5 years. The reason I didn't quote that paper here, because that's the only paper which sought in the entire world. So when you have somebody doing 100 cases of one sort, and none of the rest of the world is doing it, you start asking questions about really whether the kind of quality of the procedure and all that stuff. I could quote that paper in my support here. It's robotic. That same team has done, after laparoscopy, they took on robotic, and they have published 100 cases of robotic of 5 years approximately follow-up.
Right.
But my contention is very clear. I'm starting from scratch. You may call it rediscovering the wheel if somebody's already done it. But the problem with that team's approach is they haven't really given us technical data of how the procedure differs and how you could advocate the procedure to people who are doing, for example, Dr. Yadav advocates of open hepatojejunostomy. So there have been no converts. That paper was published more than a couple of years back. There have been no converts. So from that perspective, I think if I have to go down this path, it is rediscovering the wheel all over again. I'll have to compare it to, not to their paper, but to his results, or people who are doing open HJ, their results. That's the reason that paper is not quoted in this.
Nonetheless, the future of minimally invasive surgery for this pathology looks promising.
Yeah. Can I just put it out here that I was a firm advocate of not using minimal access surgery for this operation, because to my mind, apart from Shrikant or a few others who are very, very good in laparoscopy, you simply don't have the dexterity to do what was shown in the open surgery, that handling the 50, 60 sutures, placing them in appropriate bites. In my mind now, the robot has changed all that. We have that dexterity inside the abdomen with probably a better view. And the last bit of it is that when you did a hepatic jejunostomy and tried to teach it to your resident, the only person who learned was your first assistant, because nobody else could see what is going on. Compare it to this, I think it's far better a teaching tool. And at the extreme end of it, I've never seen the higher plate being lowered this clearly when I was learning HJ. So to my mind, this is possibly a way to be explored. I'm not saying this is the end of it, but it should be explored definitely and given a chance.
Thank you.
I don't have personal experience on post-cholecystectomy, but yes, benign strictures, post-Whipple who have strictured with post-choledochal cyst, we have revised, we already have a jejunal limb there. So that's the experience, not in post-cholecystectomy. But I think it is definitely feasible, having done, doing these hepatic jejunostomies and other procedures routinely. We don't have personal experience, but I think type 2, 1, 2 should be great for doing, and those are lesser numbers, generally speaking, those which are referred to us, which is 3 or more. So I think 1, 2 with laparoscopic groups which have experience in this, I think this is this definitely can be done as in open, is what I would say, and people can be trained to do. About the access loops, which Radha was asking, SGPGI data, this was 300 patients published in 2006. So I know that we had given up by then. 2002, he had given up on access loops because 42 were done in those 300. And I think in 2, it was to be used, but they couldn't succeed. So when you make it, you can't use it, so they had to go percutaneous. So I think access loops are given up.
Ramesh?
Yeah, I just want to congratulate Rajneesh for pointing out that it's not robotic. Can you hear me?
Yeah. Louder, sir. Closer to the mic, maybe.
How about now?
Yeah.
I want to congratulate Rajneesh for pointing out that if it's robotic, laparoscopic, or open, it's the boxes that are important. And I think future discussions must revolve around boxes, which have to be ticked rather than the medium used for the technique. And if you get the boxes ticked, and I think because the boxes were not ticked, that's why the post-cholecystectomy biliary stricture happened in the first place. And you don't want to make that mistake all over again. And I think it'll be meaningless to wait for 900 cases and 15 years to decide whether one is better than the other, and then discover actually that robotic is way better than open surgery, and then of course ban open surgery. That wouldn't happen. But if you get the boxes ticked, it should be all right.
Anyway, see, the feasibility is established. The advantages are probably common with any other minimally invasive surgery, but particularly for HJ, is there any advantage? Is what one would like to know. And then the difference between the open and the robotic, all I could see is the use of ICG, and you don't dissect you don't release the liver completely. Apart from that, it's almost the same as the open surgery. So that remains the same, right? But all other discussion, I think we'll have to wait for a few years to see the long-term follow-up.
Can I make a comment on this?
Yeah, please.
I wouldn't say that it is exactly the same as in open, because in fact we have modified our open procedure after we started in laparoscopic biliary stricture, because now we have an experience of about 80 plus cases. And one of the things is that we don't have experience about robotic, but I think more limited dissection we are able to do with that, and that is what we have, because we were conventionally taught that for an open hepatocholangiostomy to mobilize the entire thing. But now in that focused area, you can go in and have that with similar results. And the second point I would like to make is what you just said in the previous talk, that we often use a hepaticoduodenostomy. Same for, we started doing it with choledochal cyst, and then we realized that in a lot of those cases, even the duodenum is able to reach even in biliary stricture. So that is what we have been doing. And the third point I would like to make about is the access loop. I think, Rajneesh, you are right that maybe less often it is used. I hope it is used. The need arises much less often. But having said that, it is still better to keep that as a policy. Like a lot of time, we now selectively do it, but in some of the high-risk cases, and we have used it very less often, maybe about 3 cases that I can remember. But in one of them, they were not able to percutaneously go, so we did a small incision and gave an access to the endoscopist. So these are just 2-3 points.
I kind of agree with most of the comments, sir, except one, and that is limited dissection. That is not the aim of this operation. It has to achieve what the open surgeons do exactly, which means that there has to be a mobilization of the segment 4, lowering the higher plate completely from the cystic plate to the umbilical fissure, and achieve a stoma which is large. I'm sure you didn't mean what that, but probably it came out as...
Maybe I'll just clarify so that it doesn't go with the wrong message, because in that area, certainly you do all those things, lowering the higher plate, opening the duct as you would do in an open. But I was talking about is the dissection lateral to it, because we were taught always to go from the lateral, and the liver and all that was mobilized completely. That is what I'm talking about, is probably... but otherwise,
techniques are going to evolve. See, techniques are going to evolve over a period of time, and we would realize more and more in future. The last comment, please.
We tried all permutations and combinations. In fact, the first video you saw, we started using the bobbed suture continuously. And we've tried the technique which you told us that the way Leslie Mungart has described that, take anti-wall stays and as well as stays in the posterior wall. There are some modifications which are bound to happen. And one of the modifications which laparoscopy taught us long back is that you can't handle too much suture in the abdomen. You get into a mess. So the only ones what we do now, as reasonably standardized with us, is the last, say, 3 or 4 sutures on the anterior wall are taken as pre-placed and put on clips and put on the side. And sometimes even those get entangled because there's too much suture to handle in the abdomen. So I guess.
You started with Bhav suturing questions.
No more.
Right Bhav sutures.
No more.
Gave
No, no.
notices, but we are also
No, Bhav sutures have very bad needles, to be honest with you. They have provided us with very limited amount of needles. That doesn't provide us enough kind of...
Yeah, we are now exceeding. Thank you, Dr. Rajneesh.